Okay, let's just see if we can find it. I can find the slides. Okay. Okay, well, I hope you can see the slides, and if people want to ask any questions, please just speak up, while I'm talking, or we can have questions at the end. And if you can mute your devices while we're talking, that'd be good, because otherwise there's a lot of background noise. So today I wanted to talk about meningitis and encephalitis in children, but maybe there's a better term for that, because not all children who look like they've got meningitis or encephalitis have that. They may have a different cause. So let's call it febrile encephalopathy. So that covers meningitis and encephalitis and other infections that affect the brain. So we'll just call it febrile encephalopathy in children, but it covers meningitis and encephalitis and cerebral malaria and TB meningitis and a variety of other things. But I wanted to talk about how we make a distinction between these two different, there's some more people coming on. I'll just admit all these people now. I wanted to try to explain how we make a distinction between the different causes of meningitis and encephalitis and how we would manage such a patient. And I think it's good to go back to first principles of managing any sick child. And this is how we teach people to manage any sick child, that there should be first of all, a triage process. So this is this young girl, she's 7 years old, and she presented to an emergency department. And maybe what can you say about her? Can anyone make any comments about her? Well, she looks either asleep or she looks unconscious, doesn't she? It's a bit hard to tell. Can you see anything else about her? This was her, I'll just admit some more people. This was her. She looks pale, that's right. She does look pale, quite right. She looks pale. And this was her presenting problem. She was a 7-year-old girl who presented with fever and a seizure. She'd only been unwell for 2 days, or at least according to her parents. She'd been unwell for 2 days. She had a cough and she had a fever and she had a discharge from the right ear. Okay, you can perhaps see if you look that the right side of her face looks a little bit more swollen than the left side. Maybe you'd think that's an angle of the way the photo's taken, but perhaps her right side of her face looks a bit more swollen. So she had the discharge for the ear for 2 days, and then she became very sleepy that morning, and her father tried to wake her and he couldn't wake her up. He brought her into the emergency department, where she started having a seizure that was affecting her left arm and her left leg, and then it went to her whole body. By the time she was seen by the doctor in the emergency department, she was snoring. She had some sort of snoring breathing, and she was cyanosed with an oxygen saturation of 82. So when you hear that story and look at this child, what do you think about? Well, the first thing you should consider is whether or not she's got any emergency signs that require emergency treatment, right? And so when we manage a patient like this, we're thinking about First, do they have any emergency signs? Does this child have any emergency signs? What emergency signs does she have? We'll just perhaps go through them. Whenever you're thinking about a child, the care of any seriously ill child, you should go through this process. So there should be triage first, where you do a basic assessment, and then you look for emergency signs and you provide emergency treatment. And then you've taken a very brief history to start with, but then you take a more detailed history and do a more detailed examination. And then you might need some laboratory investigations. And then you might come up with a main diagnosis, but you might have some other diagnoses that you think are important as well. And then you work out your treatment plan and then decide what supportive care and monitoring is required for that child over the next few hours and days. And then you think about discharge planning and then follow up. And regardless of what the problem the child presents with, whether it's severe pneumonia or severe malaria or meningitis or encephalitis, then these stages of management apply to all of those children. Triage, emergency treatment, history and examination, laboratory investigations, coming up with a clear diagnosis, but also considering some other ones that might require treatment or some other complications, some comorbidities even, then providing the treatment, doing supportive care, monitoring discharge planning and follow-up. You should use those stages of management in any child you look after. So the triage, when this child is presented to the emergency department, triage would look a bit like this. First of all, you take a brief history of the problem, and that was that the child had been unwell for only 2 days with a discharging ear and a cough and a fever, and then had a seizure. That's as much as you need to take to start with to get a good idea of what might be going on. Then you take the temperature of the child and weigh the child. The weight is important, isn't it? Because you need to know the weight of the child to calculate drugs that you would require, that the child would require. So unless the child's in a very severe state, then you should try to weigh the child and take the temperature. Then you should do a basic assessment of the child to assess the child's airway, assess the child's breathing, and the child's circulation. So when you assess the child's airway, all of this process really takes about 30 seconds or a minute if you practiced at it and can do it well. So the more you do this sort of assessment in children who are very unwell, the better you get at it. So you listen for stridor or obstructed breathing. So this child, if you remember, was snoring and had cyanosis. So probably the child's got some obstructed breathing, isn't it? You look for cyanosis, which this child had, and for signs of respiratory distress, and you check the oxygen saturation. So could those who just come, maybe mute your device so that there's not feedback? If you can, thank you. Thanks, Leah. So you listen for stridor or obstructed breathing, look for cyanosis, check the oxygen saturation, and then you need to assess the circulation. We've talked about this before, but you need to feel the hands and the feet, and you feel the skin temperature of the hands. If they're warm, that's good. If they're cold, that's not good generally. Feel the pulses. You can feel the pulse volume, and you can check the capillary refill time. Okay, so that's one assessment of the circulation. If you've got time and you've got the facilities, you can measure the blood pressure as well. And then you assess in terms of disability, or D for disability or neurology, you should assess for lethargy and level of interaction. So that's all you need to do to detect emergency signs. So these are the emergency signs that in the World Health Organization guidelines: obstructed breathing, severe respiratory distress, central cyanosis, signs of shock, coma, convulsions, and severe dehydration. So you should look at the child for any one of these, going through the A, B, C. Okay. So of those signs, the emergency signs, which ones did this child have? I'm sorry, say that again. Most children just have one or two emergency signs, but this child seemed to me to have quite a lot of emergency signs. The breathing was obstructed, so the child's got obstructed breathing. The child was cyanosed, so central cyanosis, didn't have signs of shock, but was in a coma and did have convulsions. So this child's got quite a lot of emergency signs, and you need to know how to manage this child urgently, isn't it? If you see emergency signs, you have to stop what you're doing and you have to give emergency treatment, all right? And so these are the emergency signs this child had: obstructed breathing, severe respiratory distress, central cyanosis, coma, and convulsions. Okay, so you need to stop what you're doing and give emergency treatment for those signs, and that would require these sorts of things. So positioning the child usually in the coma position on the side. All right, this is the coma position, but ideally 30 degrees head up. You should keep the neck extended in the midline so you open the airway. Sometimes it's necessary to pull the jaw forward to open the airway. You can turn the child on the side to reduce aspiration. You give oxygen. You need to calculate the amount of fluid the child should receive, whether it's a bolus of fluid if they've got signs of shock or not. You need to think about what treatment to give. So giving antibiotics for meningitis, if you thought that was the diagnosis, or cerebral malaria. Because the child's unconscious, you should check the blood sugar. And because the child was convulsing, you should decide on what anti-convulsant to give. So these are all things that you should be able to do in the first hour. Okay, there's a golden hour of resuscitation of children, and especially that, and it's in a particular order, right? So that you protect the airway first, protect the breathing next, and the circulation third, and then think about giving antibiotics and give antimalarials, checking the blood sugar because the child's unconscious, and giving an anticonvulsant. So all of those things, really, there's a golden hour, but you should try to do them in the first 15 minutes or so, all of those things, okay? And it's not that hard if you've practiced that to be able to do those things, okay? Now, I said that this talk would be about bacterial meningitis and encephalitis, or febrile encephalopathy. And so this child who had this problem, she was a 7-year-old girl with fever and a seizure, and she had a right ear discharge and a seizure in the emergency department, came in hypoxic. What could be wrong with her? What do you think could be wrong? Well, this would be a common presentation of a child, wouldn't it? You know, we see children present with respiratory distress, with dehydration, and with this problem of febrile encephalopathy. This is a very common presentation, and we need to know how to treat this properly, and therefore we need to know what the possible causes are of, for example, meningitis. And so this would be a common presentation of children who present with meningitis, and these are the causes of meningitis. So for those, especially the pediatric trainees, you need to know the causes of meningitis in children over the age of 1 month, and also meningitis that occurs in neonates. All right, and so over the age of 1 month, the common causes of meningitis are Streptococcus pneumonia and Haemophilus influenzae type B. They're the two commonest causes, and then we sometimes see children who've got Neisseria meningitis, which is another type of bacteria. And we often see children who've got Mycobacterium tuberculosis, don't we? TB meningitis. And so they're the bacteria that cause meningitis in children over the age of 1 month. If in neonates have sometimes those causes, but sometimes some extra causes. Okay, so if a neonate has meningitis up to the age of 2 months, then they may have some additional causes. They might have E. coli meningitis or Escherichia coli, the gram-negative meningitis, or they might have group B streptococcus. And usually these are vertically transmitted from the mother during the birth process, but they don't cause meningitis immediately. They might cause meningitis in days or weeks or even up to a month later. So for those for children with bacterial meningitis, the treatment is ceftriaxone. In the past, we could use chloramphenicol, but as you probably know, more than 70% of the Haemophilus influenzae type B bacteria now are resistant to chloramphenicol, so we have to use ceftriaxone. And the dose is 50 milligrams per kilogram, 12 hourly. Sometimes people give 100 milligrams per kilogram daily, but probably 50 milligrams per kilogram, 12 hourly is a bit safer. And of course, when you've got a child like this young girl, this 7-year-old girl, she might also have cerebral malaria. So it doesn't hurt while you're getting the blood film and while you're waiting for the rapid diagnostic test to come back. If the child comes from a malarious area, then give a dose of artesunate. And that, you know, the dose of artesunate, or you can look it up in the standard treatment book or the Frank Shan drug doses book. It's 2.4 milligrams per kilogram. And it is important to not, even though malaria is a bit less common these days, I think we're still actually seeing quite a lot of cerebral malaria and severe malaria. And it might be that there is even more of it around than what there was a couple of years ago. So as I say before, you've got all the tests, whether it's a blood film or the full blood count or the blood culture or the lumbar puncture, you can give ceftriaxone and you can give artesunate, right, which will treat cerebral malaria. There's another type of meningitis that's much less common, but I just wanted to mention this because it's a bit like what this particular child had. And that is, sometimes, usually meningitis is just an inflammation of the brain, an infection of the brain, but sometimes there's an abscess formation, all right? And I think we see quite a bit of this, quite a bit of cerebral abscess. And it's much less common than bacterial meningitis, although it is a form of bacterial meningitis. But you should particularly think about cerebral abscess. If a child has mastoiditis, like this girl had, a purulent drainage of the right ear and a swollen right side of her face, so likely mastoiditis, or if you see a child who's got sinusitis. And I think we should all think about how to diagnose sinusitis. And the way you diagnose it is most of those children have quite a bad headache. So they present with headaches or pain in their face. And when you tap on their cheeks or tap on their forehead, it's exquisitely tender. And so you should, if ever you see a child who, especially over the age of 7, it's unusual to get sinusitis under the age of 7, but it does occur over the age of 7. And the reason why sinusitis is a bit more closely related to cerebral abscess is because it's an infection of the bones, the sinuses or the holes, the air-filled holes in the bones within the facial structures. And if they get infected, then they can spread up the veins into the brain. And so if you see a child who's got a focal neurological deficit like this girl had, she had a seizure involving the left arm and facial swelling, then think of a cerebral abscess. It's also more common in children with cyanotic congenital heart disease, and we see quite a lot of that in children who've got tetralogy of Fallot. They're more likely to get cerebral abscess, but it really is just it's a form of bacterial meningitis. But there are some differences in that the causes are a bit different, right? I said the causes of bacterial meningitis are mostly standard. They're Streptococcus pneumonia or Haemophilus influenzae or Neisseria meningitis. But if a child's got a cerebral abscess, then the causes can be different. They're often other types of bacteria, particularly the bacteria that exist in your mouth. So different forms of streptococci. Sure, you can certainly get Haemophilus as well, or staphylococci. You don't need to know too much about the different causes of cerebral abscess, just to be able to identify the children that are a bit more at risk of cerebral abscess, like if they've got a mastoiditis or a sinusitis, or they've got staph infection elsewhere, then you should think that maybe they've got a cerebral abscess. If they look like they've got meningitis or they've got a focal neurological deficit. And the reason to make a distinction is because these children need ceftriaxone for sure. You could also give them artesunate while you're waiting on the blood film, but they also need some other antibiotics that would cover other pathogens, other bacteria. So they need flucloxacillin and metronidazole. And sometimes within the cerebral abscess, there's more than one bacteria. Usually with bacterial meningitis, there's only one bacteria, but sometimes within a cerebral abscess, there's more than one bacteria. And so it is important that we identify children who might have a cerebral abscess. And if you can, then do a CT scan, because that's what it looks like. You can see a ring enhancing lesion. This is a cerebral abscess here, okay? I'll show you some more cerebral abscess in a while. But just remember, most children with meningitis, all they need is ceftriaxone. But if you think a child might have a cerebral abscess, then adding flucloxacillin and metronidazole is a good thing too, okay? Now, this is the main part of the talk, because I wanted to explain, while we focus a lot on antibiotic treatment, what we have to be good at is preventing secondary brain injury, right? And so we can't do a lot of, in children who've had a brain injury, if they've had like a traumatic brain injury or an infective brain injury, or they've got some other form of brain injury like a bleed, we can't do too much about the primary brain injury apart from giving antibiotics. But we can do a lot about the prevention of secondary brain injury. And the reason I think this is important is because many children come into the wards and they're not too bad to start with, right? They might have had a seizure, but they're reasonably a bit interactive and they're sort of conscious, semi-conscious. And then over the coming days, they often deteriorate. Now, you know, these sort of children, they deteriorate, and we wonder why. And often when children deteriorate, it's not because of antibiotic resistance, it's because of secondary brain injury, okay? And we have to be, like, as doctors and nurses, we have to be experts in the management of secondary brain injury, in the prevention of secondary brain injury, all right? That's our job when a child comes into the ward, is to treat their underlying problem, but also prevent any secondary brain injury. And the causes of secondary brain injury are these. So hypoxia, of course, if a child comes into the ward and they've got severe respiratory distress and they're hypoxic, then if they've got meningitis, then that can make their brain injury much worse. So we have to correct their hypoxia. Hypotension is another one. So if a child's got low blood pressure when they come into the ward because they're a bit septic with meningitis, then often they won't get enough blood flow going to their brain and enough oxygen going to their brain. Right, so hypoxia, hypotension. If their blood sugar is low because we haven't fed them, or they're severely unwell, or we've given them intravenous fluid without glucose, and they get hypoglycemic, that can make their brain injury much worse. So we have to prevent hypoglycemia. Sometimes children with meningitis or encephalitis, if they have a seizure or they have severe respiratory distress, or they have a bit of brain swelling, they may have hypoventilation, like their breathing might be slower, or they might have periods of apnea. And if that happens, then their carbon dioxide level goes up, and that can cause more cerebral swelling. So it's very important that children have regular breathing and they're not hypoxic. So they're not hypoxic, and they've got good breathing, not too slow breathing, or not having periods of apnea. It's really important. And then persistent seizures can sometimes cause secondary brain injury. Now, of course, for most children who have epilepsy, if they have a seizure, that doesn't cause a brain injury. They'll get over that and they'll come back to normal. But if a child's got an underlying cause of epilepsy, like they've got meningitis or they've got encephalitis, then if they have persistent seizures, then they can have a worsening secondary brain injury. And then, of course, there's cerebral edema, which can occur if you've got meningitis. but it also can occur because we give the wrong intravenous fluids or we give too much intravenous fluids. And then there's sodium imbalance, and that can also occur because we've given the wrong intravenous fluids or too much of that. And so this is our job in looking after such patients, to try to prevent secondary brain injury from all of these different causes. Okay. Now, I know some of you have access to CT scans and some don't, but I want to try to explain a little bit about CT scans and what they can tell us. All right. And so when you're looking, this is a normal CT scan of a child, a 2-year-old child. And I won't go through all the different cuts, but what you can see is that these are the ventricles, the black, everything that's water is black. All right. So this is the water inside the cerebrospinal fluid, inside the ventricles. This is normal. And you can see that there's area of what we call the grey matter, right? This is the grey matter here. And then the internal part is called the white matter. This is the white matter here. And you can see that there's a difference between, it's a bit hard, but you can see there's a difference between the grey matter and the white matter. That's what we call grey-white differentiation. And what you're looking at here, where you see the dark parts, is where the brain folds in, where there's lots of different folds to the brain. That's normal. This is what a normal CT scan would look like. Right? This is what an abnormal CT scan looks like in a child who's got meningitis. And what you can see there is that the ventricle is very small, isn't it? You can't see the normal grey-white differentiation. It all looks just very swollen, okay? And so this is a child who had bacterial meningitis from pneumococcus, right? And you can see that his whole brain is swollen, very different to this one, right? So I just wanted you to see that so that you can get an idea of how sometimes meningitis can affect the whole brain, not just the coverings of the brain. Normally, meningitis it just affects the coverings of the brain, the meninges, all right? But sometimes it can affect the whole brain as well, okay? Sometimes it won't affect the whole brain, but it'll affect just part of the brain. So when you're looking at a CT scan, you look for symmetry or asymmetry. And I want you to just have a look at this scan and see that is clearly asymmetry in the left side. And in this part here, see how it's darker. This is darker than this side, okay? It's darker and it's larger. And this young girl, she presented just last week or the week before, and she had a left-sided inflammation or edema, all right? And so from that, she couldn't move her right side, okay? So this was a form of meningitis or probably TB meningitis. I hope you can see that. If you can't, don't worry, but the main thing is you look for asymmetry, symmetry or asymmetry. The left side should look like the right side, okay? This is another child who also had presented with unconsciousness and fever. And can someone tell me what you see on this CT scan? This was an 8-year-old boy who presented with unconsciousness and fever, and he had headache and tenderness on tapping his forehead. So what can you see? Remember, you're looking for symmetry or asymmetry. I think some people can see it. Can someone just say what they see? Mispa or Melissa, what can you see?
It looks slightly down on the left frontal lobe area.
That's right. You can see that this area here looks just darker, doesn't it? There's clearly an area of edema, which is anything that's blacker is extra water, all right? And so there's an area of inflammation or edema on the left side in the frontal region. And this child, as I said, would look very much like the other one, couldn't move the right side and had frontal headaches. So when you're looking at a CT scan, you look for symmetry or asymmetry, I won't go into too much into CT scans, but I think it's just useful for us to know the basics of how to read CT scans. All right. Okay. So when I said before that our job is to prevent secondary brain injury, to prevent brain injury from hypoxia or hypotension or hypercarbia or hypoglycemia or persistent seizures or fluid imbalance and cerebral edema. These are the things that you can do, the basic things you can do. Well, first of all, you can nurse a child 30 degrees head up. And if you do that, if you nurse a child, all children in the ward should be 30 degrees head up, but especially children who've got a brain injury. And the reason for that is because it reduces their intracranial pressure, right? So when we are standing up, our intracranial pressure is lower than when we're lying down, right? And if you have a child nursed at 30 degrees head up, you can prop up the bed or wind up the bed so that it's 30 degrees head up, then their intracranial pressure will be lower. It's ideal if the child, to nurse the child in a neutral position, right? Not to have the child's head right down so the airway might be obstructed, but in a neutral position, 30 degrees head up, right? You provide whatever airway support is needed for a child, of course. And so usually all that means is correct positioning. You usually don't have to do too much else. Sometimes you do, but often you don't. Give oxygen, carefully use intravenous fluids. I'll talk about how much you use, but we have to be very focused on not giving too much fluid. And if you start to see when you're monitoring the children every day, if you see their eyelids becoming puffy, then you know that they're getting too much fluid and their brain may be being swollen. So be really conscious of that. We need to monitor for seizures. We need to monitor their glucose and their electrolytes, now especially their sodium. And a child who's got a brain injury, we should aim to have their sodium just in the high normal range, right? Not low, not too high, but not low. All right. And so I'm usually happy if the sodium's 140 or 145, but I'm not happy if the sodium's 130. That's not good. And the reason for that is because if the sodium is low, then you get water shifting into cells. All right. If your serum sodium's low, then you'll have water shifting into cells, and that will worsen cerebral edema in children who've got a brain injury. Okay. You can start if a child's in the ICU or the high dependency area of your ward, you can start nasogastric feeding and you can monitor that safely, and you can have vital sign monitoring and responses. Right? So as I said, you should always nurse patients 30 degrees head up and try to have their jaw in a neutral position so that their airway is clear, and give them oxygen. But the 30 degrees head up is very important. In terms of the fluid calculation, I'll just go through it. But this girl I mentioned at the start, she was 7 years old and she was 18 kilos. And so we can work out how much fluid she needs per hour using the 4-2-1 rule, right? Now, 4-2-1 is the maintenance fluid requirement, isn't it? Using the 4-2-1 rule. So 4 mils per kilo for the first 10 kilos, so that's 40 mils. And then 2 mils per kilo for the next 8 in this case, because she's 18 kilos, right? So that's 16 mils. So the total fluid that she should receive is 56 mils an hour. But if you gave her 56 mils an hour, that's her full maintenance fluid, then what would happen would be that her face would start getting swollen and she'd get cerebral edema, right? And so in a child who's unconscious, you should never give them full maintenance fluid unless they're dehydrated, right? And so in a child who's unconscious, I usually start with half that, all right? So half of 56 is 28 mils an hour, all right? And sometimes children need a bit more, but sometimes they need less. But I think it's safe if you're giving intravenous fluids to an unconscious patient, then start about half their full maintenance fluid if you're giving it intravenously. If you're giving it nasogastrically, you can give more, right? You can give more fluid, because when you give fluid nasogastrically, our bodies work out how much it wants to absorb, all right? Our bodies are smarter. But if we give fluid intravenously, you've got no choice. The child is just getting whatever you give. And if you're giving too much, then there's no chance that they don't get that fluid. All right. So you should start with half the maintenance fluid, and then after a day or so, introduce some nasogastric feeding. Don't be too slow in introducing nasogastric feeding. And you can even introduce a small amounts and then grade up progressively over 24 or 48 hours. So our job, as I said, is to prevent secondary brain injury. And one of those causes of secondary brain injury is persistent seizures. And I think this is actually one of the reasons why we see a lot of children deteriorating. And it's not just because of the seizures, but sometimes it's because of the treatment that's given for seizures. And I'll just explain what I mean. Persistent seizures, like if a child has ongoing seizures when they've got a brain injury, then they can cause a worsening of that brain injury, because when you've got seizures, then your brain is using more or needing more oxygen and glucose and energy, right? And if your body can't provide the oxygen, glucose, and energy for the seizures to happen, then the cells will be starved of that energy, and then they will start to die, right? And so in a child who's got persistent seizures, if they've just got epilepsy, that's different. But if they've got encephalitis or meningitis or cerebral malaria, and they've got persistent seizures, then we really need to stop those seizures, right? So that's the first part of it, that persistent seizures by themselves can cause secondary brain injury. It can make things worse, as in make the child worse. But also the treatments that we give can also make things worse, all right? And so sometimes when children have seizures, they receive anti-convulsants, and the anti-convulsants can cause low blood pressure, or they can cause a child to be slower in their breathing, all right? They can cause respiratory depression, or even cause apnea for a brief period of time, and that might make things worse. Or the combination of the seizures and the anticonvulsants can lead to airway obstruction or suppression of breathing, like I said. And so we have always, it's a balance. It's a balance between needing to stop the seizures, which is very important, but also making sure that the anticonvulsants we give are not detrimental to the child's airway, breathing, and circulation. And that's why any child who needs more than one anticonvulsant really should be managed in an ICU or a HDU area. You shouldn't just have them at the back of the general ward if they're receiving more than one anticonvulsant. That's really important. So all children with meningitis or encephalitis or cerebral malaria should be managed in the ICU or the HDU area of the ward, and especially if they're having further seizures, okay? And there's been some studies done looking at this, looking at the effect of especially combinations of phenobarbital and diazepam on outcome. I won't go through all the research, but this was a very good study of children with cerebral malaria, where the children with cerebral malaria who got both phenobarbital and more than 3 doses of diazepam, or 3 or more doses of diazepam, they had a much greater risk of death. Now, partly that's because they probably had ongoing seizures, but partly it's because of the respiratory depression you get with diazepam, especially diazepam combined with phenobarbital. So while it's really important to stop the seizures, it's also important not to cause respiratory depression. So 3 or more doses of diazepam plus phenobarbital loading increased the risk of death from respiratory depression in this study. This is a very important study because it taught us that while stopping seizures is very important, we have to be careful about the anticonvulsants that are used. All right. So any child who needs more than one drug, such as praldehyde plus phenobarbital or phenobarbital plus diazepam, they need close monitoring of their airway, their breathing, and their circulation in the ICU. That should be like a rule that we always follow. There are some drugs, some anticonvulsants that have less of an effect on respiratory drive, and those anticonvulsants are now part of the WHO essential medicines list, but they're not always available. So levetiracetam is one, sometimes called Keppra, that's one, and the other one is sodium valproate, or sometimes called Epilin. Now, both of those drugs treatments for epilepsy, but they also treat children who've got status epilepticus, who have meningitis or encephalitis. And these are probably in some ways safer drugs than the other drugs that we had because they have less effect on respiratory drive. But if you're going to use diazepam or phenobarbital or praldehyde or phenytoin, that's fine, but you just need to manage the child in the ICU where they can get close monitoring. As far as monitoring goes, I think we should all be using something like this, a color-coded monitoring chart, all right? And you can see this monitoring chart has the temperature there, has the respiratory rate, has the oxygen saturation, it has signs of respiratory distress, the amount of oxygen the child's receiving, the heart rate, the capillary refill, the blood pressure, the AVPU score, the alert, verbal, pain, or none, the response, not the GCS, but like the AVPU score. It's a bit easier to fit on a chart. Their pain score, the blood sugar level, and any treatments that are given. And what you can see is that, say, for example, with the heart rate, if the child's in the white zone, then that's okay. They're in the normal zone. If they go into the yellow zone, then that's concerning. And if they're in the red zone, that's very concerning. And the same for the oxygen saturation, all right? If they're in the white zone, that's fine. If they're in the yellow zone, that's starting to get worrying. And if they're in the red zone, that's very concerning, all right? And so if you use the monitoring and response chart, then you need to have a method of escalating. So if a child goes into the red zone, then they need to have a doctor come to the bedside and check them out and assess them and make some changes. All right. This type of monitoring has been being done in hospitals all throughout the world, and I think it's something that we should do more often. Okay, so you can see from this child who started off, I'll just show you this child, an 11-year-old child with severe pneumonia. He started off with a respiratory rate that was very high, and then he came down into the white zone. His oxygen saturation was always, well, it was low to start with, and then it came up okay. His respiratory distress improved. So from this type of monitoring, you can see whether a child's getting closer to the white zone with all their vital signs, or they're going further away from the white zone, if they're going into the red zone with their vital signs. So this type of monitoring is very important. It'll help you if you're looking after a child who's severely unwell. Now, I'll just say a couple of other things about other treatments for meningitis. In the past, we've used steroids in meningitis, and that's still a good thing to do because it reduces the risk of hearing loss in children with Haemophilus meningitis, and it reduces in adults with meningitis their risk of dying. So the thing is about steroids, you have to give it at the same time or even up to 15 minutes before the first dose of ceftriaxone. You have to give it at the same time as the ceftriaxone. And the dose of the steroids I've mentioned is down here, dexamethasone or methylprednisolone or prednisolone for those children. All right, so using steroids is good in meningitis if you can give it at the same time as the first dose of antibiotics, and if you've got good antibiotics to give. All right. Once you've given treatment and supportive care and monitoring, you need to do some discharge planning and follow-up, and part of that is assessing for complications of meningitis and encephalitis. And we should always be alert every day when we do a ward round on a child with meningitis. You need to look for these complications, and a child who doesn't have any of these is probably going to do very well from their meningitis, but many children have one or more of these complications. So the most important, not most important, but the most common complication is actually hearing loss in children who've got meningitis. And sometimes it's transient, it's because they've got a middle ear effusion, and sometimes it's permanent because they get nerve damage to their acoustic nerve. Right? And so you only know that after following them for some months. Usually it takes up to 6 weeks for their conductive hearing loss to get better. If they've got a middle ear effusion, after you give them antibiotics, it can take 6 weeks. But if they've still got hearing loss after 2 months, when you follow them up, then likely they've got what's called neurosensory hearing loss or nerve damage from their meningitis. motor dysfunction is probably the thing we see the most, even though it's not the most common. The hearing loss is more common, but we don't always see it. We don't always detect it. But motor dysfunction is quite common. So many children with meningitis, because they have inflammation or edema of the brain, they might have an ischemic stroke, right? But even if you've got like edema of one part of the brain, that usually recovers. It's only if you've had a stroke that a child may be left with a hemiparesis or a hemiplegia, or they might, if it's really bad, develop cerebral palsy or spasticity. And so cerebral palsy after meningitis can be anything from very, very mild, just maybe some weakness of one arm, to something that's like spastic quadriparesis, a very severe form of cerebral palsy in children that have extensive inflammation of their brain. Visual impairment is also common, and that's often because of occipital inflammation, like inflammation in the visual area at the back of the brain. Epilepsy is relatively common in children after meningitis, hydrocephalus, and subdural collection. Sometimes those things occur after meningitis. I won't talk too much about febrile encephalopathy in general, but I just wanted you to realize that not all meningitis is due to bacteria. Okay, there are many different viruses that cause meningitis, and there has been the reason I talk about this is because there's been some very good studies coming from P&G that have identified the causes of meningitis being not just bacteria, but other things as well. So of all the studies of this febrile encephalopathy, meningitis encephalitis, around the world, 3 have come from Papua New Guinea and some from other places, mostly India and Papua New Guinea. They're where the most studies have come from. And one of the studies was by Dr. Anger, a very good study of the etiology, the causes, the presentations and the outcome of febrile encephalopathy in children. And the other study was by Dr. Kiramat. Now, I won't go through it all, but the main thing to know is that viruses are about as common as bacteria in causing meningitis, right? Viruses are about as common as bacteria. And then cerebral malaria is almost as common. And TB meningitis is about half as common. So that's up there in terms of the causes. So they're the big 4 causes: viral meningitis, bacterial meningitis, cerebral malaria, and TB meningitis. Won't go through all the others, but there's lots of different other causes that you will have heard about, like cryptococcal meningitis and other things. Okay. Of the viruses, these are all the viruses that are in order of frequency, but it depends on where the study's being done. And so in some parts of Asia, Japanese encephalitis is very common. Enterovirus is quite common in Papua New Guinea and other parts of the Pacific, but and then there's other viruses that sometimes cause viral meningitis or viral encephalitis. You don't need to know really what they are, just to know there's lots of different viruses that can cause encephalitis. Dr. Anger's study identified a lot of different causes. So bacterial meningitis in 33 of 149, but also a lot of other causes like malaria, cryptococcus, Japanese encephalitis and dengue virus, and then a few other causes. And similarly with Dr. Kiramat, Dr. Kanera Kiramat's study, she found 5 cases of Japanese encephalitis, so it's really there, 5 cases of dengue, and then also some bacterial causes. So the main thing to remember is that viruses and bacteria are about as common as each other, and don't forget cerebral malaria, and don't forget TB meningitis. Okay, and then there's some causes of febrile encephalopathy that are not due to infections. Okay, they don't always present with a high fever, but they look a bit the same. And I just want you to remember these. So sometimes children will look like they've got meningitis or encephalitis, but in fact they've had cerebral trauma, or they've got hemorrhage, or they've taken some toxin or drug and they've been poisoned, and so they'll be unconscious or having fits because of that. And sometimes they might have even high blood pressure. So we've talked about how low blood pressure is dangerous, but also having high blood pressure can sometimes lead to seizures and encephalopathy. And so that's why we always need to measure the blood pressure in such children. And then sometimes children with epilepsy will also have come in with what looks like meningitis or encephalitis, but it's just their epilepsy causing more and more seizures. All right. So think about non-infective causes also of febrile encephalopathy as well. All right. So these are, for example, just some CT scans of different causes of meningitis. All right, not bacterial meningitis. I've shown you some scans of that, but this is clearly a child. It's a child who is 10 years of age, and he presented with, again, a sudden onset of headache and fever and poor conscious state and seizures, and he had a cerebral hemorrhage from an AV malformation, arteriovenous malformation in the brain. That's not very uncommon. This was a child who had was having treatment for her leukemia, and she got very high blood pressure and started to have seizures and was poorly conscious, and that was because of hypertensive encephalopathy. Right, and when you do a CT scan, you often see the inflammation in the back of the brain. It's a condition called PRESS. Sometimes people call it PRESS, but just remember hypertensive encephalopathy. So if you see a child who is unconscious or is having seizures, then measure their blood pressure, because if it's very high, then it might be they've got hypertensive encephalopathy. And this is a CT scan. You, having looked at the other types of CT scans, you'll realize that there looks like there's a very dark area around here. And this is what you often see in viral encephalitis, where there's just generalized swelling of the brain. Right? So this was what's called HHV6 encephalitis. And HHV6 usually just causes a febrile illness like a viral rash in children. It's usually very minor, but sometimes it causes encephalitis. And it's actually quite a common cause of encephalitis and febrile convulsions in children. So now remember, most children with febrile convulsions don't have encephalitis. They just have a fever and a seizure, and they'll get over it pretty quickly. But some children rarely have this type of inflammation of the brain. But remember, most children with febrile seizures, they recover quite well, quite quickly. All right. I just wanted to show you this because this shows all the causes of meningitis and encephalitis, not the causes, but all the cases. These are thousands of cases of meningitis and encephalitis, and this is the case fatality rate. And this is all for almost 10 years. This is a 10-year period. And you can see that there's been some improvement, that the case fatality rate is now about 5% less. So it was about 20%, and now it's about 15%. But it's still very high. All right, case fatality rate of 15% for all cases of meningitis is still quite high. And I think that just goes to show that we've got a lot of improvement to do in terms of the way we can manage and prevent these types of infections. And so that's why I wanted to talk about meningitis and encephalitis today. So I'm just going to finish on what we can do about meningitis in prevention. And as you know, for the last 10 years, there's been 2 vaccines that protect against meningitis, and they're the Haemophilus influenzae type B vaccine, which comes in the pentavalent vaccine, which children should receive at 1, 2, and 3 months. That was introduced, well, it's 14 years ago now. And that's a special vaccine, very important vaccine, Haemophilus influenzae vaccine. If you don't see too much Hib meningitis these days, it's because of this vaccine. We used to see very, very frequently, several cases a week of Hib meningitis, and now it's quite rare. And in 2014, a new vaccine was introduced, a pneumococcal conjugate vaccine, PCV, we call it these days, PCV, and that has also been very important in preventing pneumococcal meningitis. But as I said, there's lots of different causes of meningitis that are not Haemophilus influenzae, and they're not pneumococcus. So we still have to get good at treating meningitis, and we still have to get good at preventing secondary brain injury. There are a couple of other vaccines that will protect against meningitis too. As you know, BCG protects against TB meningitis, and measles vaccine, even though measles meningitis is pretty rare, it protects against measles meningitis and also, of course, SSPE. So not only is it the Hib vaccine and the pneumococcal vaccine that protects against meningitis and encephalitis, but also some other vaccines as well. All right. So I just go back to the care of any seriously ill child. And remember that children with meningitis or encephalitis, they are seriously ill. And we should follow these stages in the management of every sick child. So triage, emergency treatment, history and examination, laboratory investigations if needed, coming up with a main diagnosis, but also being open to other diagnoses. Like you might make a diagnosis of meningitis, but also think to yourself, well, does this child also have cerebral malaria, or do they have a cerebral abscess, or might they have TB meningitis? And you've got to then go and get more information to see whether those other ideas, those other diagnoses might be true. Then we come up with a treatment plan. We provide supportive care and monitor the child closely in the ICU or the HDU. And then we have discharge planning, and that means assessment of complications and deciding what is required to get this child home and what supports the child will need and what follow-up the child will need. And then we obviously have to follow these children up because the complications that can be considerable. But also, if you follow children up with meningitis, you can also put in place early intervention to try to help them if they're starting to get visual impairment, or they've got hearing loss, or they've got motor dysfunction. You can start putting early intervention in place to try to minimize the effect of these complications that they might have. And we shouldn't forget that we have to prevent meningitis if we possibly can with vaccines. So that's all I want to say today about meningitis and encephalitis, but I'm happy to have any discussion or feedback, or please make any suggestions that you have about what we've talked about or anything like that. So over to you.
Prof.
Yeah.
I had a question about phenobarbital.
Yes.
It says you can give it IV or IM.
Yes.
Is it more dangerous to give it IV in that it's causing the respiratory depression, or would it be safer to give it IM? And how would we give the maintenance dose IM as well, or we can still give the maintenance dose IV? Which would you recommend?
Yeah, that's a good question, Annette. Thanks. I think if you're giving a loading dose, no, it's not any more dangerous to give it IV because the child doesn't have any other phenobarbital on board. And I think it's okay to give it IV or IM as the loading dose. Either one is okay. And usually in a child who's requiring a maintenance dose, I try to then give it enterally. So of course, if they're having further seizures, you might give a top-up loading dose of phenobarbital, either IM or IV. But usually the maintenance dose I would give by nasogastric tube or orally if the child can take it. If they can't take it, then I would generally give it IV. I don't think it's any more dangerous. It's usually the giving top-up for reloading is a bit more dangerous. So if a child needs reloading, it's like they're having another drug. So I would always assume that child's on 2 drugs and nurse them in the ICU, or if they're getting another drug on top of the phenobarbital. So I don't think it's one versus the other. The only thing is don't give it too fast. I mean, when you give any anticonvulsant as a loading dose, whether it's phenobarbital or phenytoin, you should give it over half an hour. Just so as you can monitor their blood pressure and their respiratory rate and things. Yeah. Does that make sense? Yeah.
Yeah. Thank you.
Mispa, did you have a question?
Yes. The role of mannitol is it significant in helping reduce cerebral edema?
Yes, thanks, Mispa. That's a very good question. And I think it does have a role, actually. And I think the role is not a standard empirical role, as in not every child with meningitis, definitely not, doesn't need mannitol. But if you've got a child who has a significant depression in their conscious state, and you're doing all the other things, you're protecting them from secondary brain injury in every other way, protecting them from hypoxia and hypoglycemia, and you're not giving them too much fluid, then I think it's useful for about a 24-hour period to give a small dose of mannitol, and that can be about 1/4 gram per kilogram, and you can give it every 6 hours, but usually only for about 24 hours in the very acute stage. Don't give it after that. One thing I didn't mention in detail was that when I didn't mention blood pressure too much, but it's really important that we monitor children's blood pressure, all right, when you're trying to prevent secondary brain injury. And you should try to have their blood pressure in the upper range of normal, right? Not just normal, not the low limit of normal, but the upper range of normal, right? And the reason for that is because that gives a bit more driving perfusion pressure to the brain. And even if their brain's a bit swollen, you'll still get blood flow going into the brain, right? And so you should try to, when you're doing all those things, 30 degrees head up, giving oxygen, protecting their airway, making sure their blood sugar's okay, not giving them too much fluid, correcting dehydration, but keeping them, half maintenance, and giving them mannitol every 6 hours for just 24 hours, and also keeping their blood pressure in the upper limit of normal, all right? So they're the things that you should be doing, okay? If you give mannitol for more than 24 hours, then you start to get the complications of giving too much mannitol, and that can be dehydration and other things. So don't do that. But just for that period where the child's acutely unwell and you're doing everything else, then it's okay to give mannitol. But I don't think it's more important than any of the other things I've mentioned, okay? It's just part of the package, all right? Part of a package of treatments you should give to these children, okay?
Thank you.
Yeah, thanks. Good question, Mispa. Thank you. Okay, well, if there's no other questions, we might stop there. But I think we've covered a lot of ground today, really. We've covered a lot of things, because meningitis and encephalitis and cerebral malaria and other forms of encephalopathy, they're quite common in our wards, aren't they? And we need to be like, these are the basics of how to manage such patients, and we need to teach these sorts of things to all our nursing staff and the junior doctors, and make sure everybody understands the basics of managing these sort of patients, so we can protect them from worsening harm. So I think we've covered some good ground today. So thanks everyone for listening and your input, and I hope you have a good week. All right. See you.
Thank you, Prof.
All right. Bye now.
Thanks, Prof.
See you.
Thank you, Prof.